Yeah. Now we move to start. All right, so this is the next slide after that video. The signs and symptoms of angina as opposed to being a heart attack. Remember, this is the ischemic cardiac cells telling you the heart needs oxygen. They're going to feel chest discomfort, maybe pain, or maybe a heavy pressure. Sometimes people will say they feel like an elephant sitting on their chest and they can't get a breath. It can be sharp, it can be dull, it can be burning, it can be crushing. Then it can radiate. This is where your OPQRST for your sample is going to be so important. Remember the S in sample, you define the symptoms with the OPQRST. That's why the medical assessment, that's a critical component, which you haven't done before in trauma. So the radiation, if you radiate to the jaw, either arm or both arms, the back, and sometimes they call the epigastric area, right? The diaphragm. They're also going to feel short of breath. They're going to become pale, gray, or ashen. They're going to be cold and sweaty. They're also going to be nauseating. Now, if it's just angina, it's not actually a clot completely blocking an artery. Then, make sure this isn't our last student. It is. Anyway, it'll be relieved by arrested oxygen. If it's just angina, it's not actually a completely blocked artery. Any questions on what angina is? The difference between angina and an AMI? No questions? All right. So what do? We don't give them high flow O2. That's wrong. Start them on 2 liters per minute of O2. We titrate to 94%. Keep them in a position of comfort. And we don't delay getting them to a hospital, and we try to get advanced life support going as soon as possible. Never wait at sea for advanced life support. Always start moving towards the hospital. Have them intercept you somewhere in between. It's very important because advanced life support can actually identify if there's an artery blocked with an EKG and actually know which artery is blocked. That can get this process started. I'm getting into what they call a cath lab, which is a cardiac surgical team that can open that artery in a second. Questions? Signs of myocardial infarction are exactly the same as angina, except it doesn't go away with oxygen and rest. Questions?
To figure out how long to take on that.
Very important. Also very important to try to get the EKG on as soon as possible. So if you look over here to the board on your left, you'll board up there. So remember we talked about the EKG, the P wave, the QRS, the T that repolarizes everything. So the reason why advanced, this is one of the few things paramedics are actually good for. They're not good for a whole lot. So, but this is one of the few things they are actually good for. So remember we had the P, that's the SA node, fire depolarizing, send the pacemaker. Then the Q, the R, the S, that's basically the actual pulse, the heart beating. Then everything's got to reset, they got to put all the dominoes back up. And that's your T wave. Okay. So when there's a heart attack, what they're going to do is they do what's called a full EKG. You'll see they put wires all over. They put 10 electrodes on the patient's body. And what they're doing is they're looking for 6 vertical views and 6 horizontal views. So it's giving them a 3-dimensional map of the patient's electrical activity in the heart. And what they're looking for is if tissue is ischemic,
then it doesn't repolarize because it's stunned, it's not working. So it has to go around it to repolarize. So instead, what you see, instead of this regular PQRST, what you see is an ST elevation. And depending on where they see that, on the 6 horizontal, the 6 vertical leads, they can tell exactly which artery is plugged. And then they send that over cellular internet directly to the cardiac surgeon or the ER doctor. Then they know to activate the team to get the people in there. So the time you get to the hospital, they're waiting to open that artery with a stent. Pretty cool, huh? So that's what, but you got to get them in there in 90 minutes or that tissue will be dead. So you got 90 minutes from the time that it happens to the time that you open the artery. Only 30 more minutes than a trauma alert.
High blood O2, regular O2, 2 liters per minute, titrate to 94%. So STEMI is a word that you will hear endlessly in EMS. So what is an MI? What does that stand for? Myocardial infarction. And what are they looking for? They're looking for ST elevation, right? So STEMI is ST elevation MI, myocardial infarction. That's what a STEMI is. You'll hear that endlessly in your observation time and clinical times. It is a critical true emergency, and if you can get them from the time the chest pain started into a cath lab where they can take a wire, go through their leg, up through their aorta, and into their coronary artery and puncture that clot, put a stent in and dilate it, get the blood flowing again, you can actually save the heart and keep it from dying. It's pretty impressive stuff, which you as EMTs can help identify and get that patient moving. So even if you're on fire rescue, you don't have an ambulance there, you can get them into a chair or something like that and get them to the front door. So when the ambulance gets there, they can do the 12-lead EKG and then just go. Instead of still having them upstairs in the far back bedroom, it's gonna take 20 minutes to get out. Make sense? So you can make huge differences on this, on whether these people make it or don't make it. Here's an animation of what they do.
Hi, I'm Nicole Hockley from Sandy Hook Promise.
We don't
I
care.
know this is hard to hear, but it's
Oh, guess we're not gonna hear it.
Coronary angioplasty, also called percutaneous transluminal coronary angioplasty or balloon angioplasty, is designed to restore the flow of blood through coronary arteries narrowed or clogged by atherosclerotic plaques or blood clots. When you arrive at the hospital, an intravenous line will be started. You will be placed on a heart monitor and you will be given an oral or intravenous sedative to help you relax. Most coronary angioplasty procedures last between 30 minutes and 3 hours. The doctor numbs the skin in your groin area and inserts a needle into your femoral artery. Once the needle is placed, a guide wire is passed through the needle and gently guided through the arterial system to the heart. The needle will be withdrawn and exchanged for a small flexible tube called a sheath, permitting access to your femoral artery. At this point, you will be given a blood thinner to reduce the risk of blood clots. Next, a soft, flexible catheter is slipped over the wire and threaded up to the heart. The procedure is monitored using a continuous X-ray imaging device called a fluoroscope. You may feel pressure as the wire and sheath are inserted through the groin and pushed through the artery, but you will not feel their movement inside your arteries. At this point, your doctor will remove the guide wire, position the tip of the catheter just inside the coronary artery to be treated, and inject a special dye. The dye allows the fluoroscope to take X-ray images called angiograms of the artery's interior. Any blockages will be clearly identified as the arteries fill with the dye. You may feel flushed or slightly nauseated when the dye is injected. Once the blockage is identified, your doctor will insert a flexible guide wire into the artery and advance a balloon-tipped catheter over this wire and into position at the site of the blockage. Rapid inflation and deflation of the small balloon pushes the vessel wall out, reestablishing blood flow through the artery. You may feel some chest pain while this is happening. The same procedure is repeated for each blockage being treated. Afterwards, your doctor will withdraw the deflated balloon and catheter from your arteries. Some patients will receive a coronary stent, which is a small tube made of wire mesh designed to prop open the artery once it has been treated. A collapsed stent is placed over the deflated balloon as it's moved into position. When the balloon is inflated, the stent expands and locks into place. After the balloon and catheter are withdrawn, the stent remains behind to hold the artery open permanently. After your procedure, a pressure bandage will be applied over the femoral artery to prevent bleeding. You will need to lie on your back for several hours, during which time you will be checked periodically for any signs of bleeding or chest pain. You may either be discharged home on the same day or after an overnight stay in the hospital.
That's how they do it. Any questions? Yes.
Does the plaque or anything like that load up on the mesh screen? That they do?
Yeah, you have to take a blood thinner for the rest of your life, or an anti-plaquing agent like Plaquenix.
Why do they not go through like the brachial artery or anything closer
Too
than?
small.
Oh,
They
okay.
can go through the radial artery.
Uh-huh.
They do have that procedure, but not for an emergency.
Oh.
Emergency, they go through the femoral artery because it's the biggest artery,
Mhm.
and they're going in blind. That's how
Oh,
they do it. They're
yeah.
going in blind and there's advanced needles, so they feel a pop, and they try to pull blood back in the syringe. Then
Oh,
once they get blood, then they run a guide wire in, then they pull the needle out over the guide wire, then they put a catheter over the guide wire, pull the guide wire out, then they advance the catheter up into the artery. So the femoral arteries are huge,
mm,
so they're a lot easier to hit. So
gotcha.
for an emergency like this,
Mhm.
going in blind, that's why they do that.
I see.
Next question.
Do they still, will they cut out that piece of the artery and replace it with a different piece?
No, they don't ever cut it out.
Okay.
So the coronary artery bypass grafts, they'll take like a vein that you don't need in your leg,
Mhm.
and they'll puncture a hole in your aorta, and
Mhm.
they'll sew it in the aorta, and they'll just go around where the blockage is, and then connect it to the coronary artery distal to the blockage to refuse that part of the artery. That's
Okay,
how, right, but they don't ever cut it out. There's no way to do it. It's too tiny, and it's in thick muscle, cardiac muscle. We can't cut it out.
okay, so they just put a new vessel in.
Yeah, they just bypass it from the aorta all the way around and then distal to it.
How big is this?
Tiny, tiny. Coronary arteries are tiny, tiny, tiny arteries. So it's just, and what it is, it's like, it's a mesh thing, kind of like a culvert. And then what they do is it just goes on the catheter and they have the balloon on top of it. As they expand the balloon, it locks into place when they dilate it, and then they just leave it in there. When they deflate the balloon, it stays in there. They leave it in. Good questions. Any other questions? All right. So here's an actual, we're not gonna watch the whole thing, 'cause it's too long. But I'll show you guys at 8 minutes and 13 seconds when they actually reperfuse the artery. So this is what they're looking at. So what they're doing is called interventional radiology. So they're advancing this through the femoral artery, and they're shooting dye, and they have what's called a, now I can't think of it, of course. We had them forever, now we don't have them anymore, but, anyway, it's an X-ray, it shows you the live pictures of what's going on. So they're actually doing this, watching the television as they're working on to the guy's leg, but, we're just gonna jump forward to 8 minutes.
This is a 57-year-old gentleman who presented with a non-ST segment elevation MI and continued chest discomfort and rising troponins. He's here for a cardiac cath to investigate his coronary anatomy. So the first picture is there. The second picture after one pass was just a clot. And then we made 2 more passes with the export catheter and 1 inflation with a balloon in the beginning of the artery. And that's how we ended up with this.
Look at that. the difference.
And now we're gonna put stents in this artery. So we'll put the 3/0 distal.
There was no
Just
blood
at the
flow
crux.
through those areas before. Pretty cool stuff. So here's how they do a cabbage.
A coronary artery bypass graft, or CABG, is performed to improve circulation to the heart muscle in people with severe coronary artery disease. In this procedure, a healthy artery or vein from another part of the body is connected or grafted to the blocked coronary artery. The grafted artery or vein bypasses the blocked portion of the coronary artery, carrying oxygen-rich blood to the heart muscle. One or more coronary arteries may be bypassed during a single operation. Before the surgery, an intravenous line will be started, and you may be given a medication to help you relax. CABG procedures are done under general anesthesia, which will put you to sleep for the duration of the operation. A breathing tube will be inserted through your mouth and into your throat to help you breathe. A catheter will be placed in your bladder to drain your urine. Coronary artery bypass surgery generally takes 3 to 6 hours. During a conventional bypass surgery, your surgeon begins by making an incision in the skin over your breastbone or sternum. He or she will then cut the sternum and move your rib cage in order to get to your heart. Throughout the procedure, your circulatory system will be connected to a cardiopulmonary bypass pump or heart-lung machine. This machine temporarily performs the functions of your heart and lungs during the surgery, allowing your heart to be stopped while the surgeon sews the grafts into place. One of 2 blood vessels is typically used for the grafts: the internal thoracic artery in the chest or the saphenous vein in the leg. For the internal thoracic artery graft, your surgeon will leave the upper end attached to the subclavian artery and divert the lower end from your chest wall to your coronary artery, just beyond the blockage. Your surgeon will then sew the graft into place. For the saphenous vein graft, your surgeon will suture one end to the aorta and the other end to the narrowed artery just beyond the blockage. With the graft securely in place, your surgeon will use electrical signals to restore the heartbeat and attach a temporary pacemaker to the heart. Once your heart is again beating normally, the heart-lung machine will be disconnected. Your surgeon will wire the breastbone back together and suture the skin incision closed. A temporary drainage tube will be placed through the skin beneath the incision. 2 other types of CABG procedures have recently been developed: off-pump and minimally invasive bypass surgery. Off-pump CABG is also called beating heart bypass grafting because the heart isn't stopped and a heart-lung machine isn't used. Instead, a mechanical device is used to steady the part of the heart where grafting is being done. Surgeons perform minimally invasive bypass procedures using specially designed instruments inserted through small incisions or ports in the chest. These procedures sometimes require a heart-lung machine. After surgery, you will be taken to the intensive care unit.
Any questions? Yeah. Pretty cool stuff they can do. So if we don't get people to the hospital in time and don't get the artery perfused, everything distal to that clot or those clots, because usually it's more than one, will die. That heart muscle is gone forever. Those people what we call, well, I shouldn't use the term in public, we call them cardiac cripples. They'll never get back to what they were prior to the heart attack. They'll be compromised the rest of their life. And in severe cases, some of these people will be in full-time cardiac shock, cardiogenic shock, where their heart just can't pump enough blood to meet the body's daily needs. So you're very, very reduced in activity and what they can do in life. Any questions? So if you have some people, I can't remember the stat anymore, because I'm getting old. There's a large portion of people that have heart attacks that never even call 911 or say that. They just write it out. Denial is much more than a river in Egypt. And these people are the ones that end up in cardiogenic shock. So when you see these people, it's after they've had the heart attack. You'll find them cold, pale, and wet, bradycardic, hypotensive, short of breath, and extremely weak. And that's a classic cardiogenic shock. They've lost a huge section of the left ventricle. Yes.
So with the AMIs, really quick, is that like inherently the tissue's gonna die on the heart? Or is there just like a time frame where if you intervene, you'll stop
90 minutes.
die? So 90 minutes.
If
and
you
then
can get the artery reperfused in 90 minutes,
Mhm.
you can stop that tissue from dying.
So the folks who have like multiple heart attacks, they're typically able to get like interventions to keep their heart from just dying on.
Not necessarily. Some people just have heart attacks. It depends on how
Before
big
it
the
gets
clot
to
is and how much tissue it kills.
Oh, okay.
So like, some people have very small or mild heart attacks because it was a little tiny clot that just killed a little tiny section of the heart. But still
Oh,
though, they're still a little bit compromised.
Gotcha, okay.
And then if they don't get the right treatment plan and the right management plan, yeah, they'll have more.
Okay,
So generally what they'll do is they'll put them on a low cholesterol diet, put them on anti-cholesterol medication to slow the arterial sclerosis that causes it. And they usually put them on blood thinners for life to keep the clots from breaking off and getting in there and doing it again. As long as they stay to that strict regimen of diet and medication, people can live for decades afterwards.
okay.
But unfortunately, a lot of people don't follow strictly the thing, kind of go, oh, I don't want to do that, then they have another one.
Gotcha.
Or my favorites are the ones that have stents put in
Mhm.
and get told, hey, you have to be on Plavix for life to stop plaque from, because the stents will actually get plaque faster than the arteries will.
Oh, wow.
And they'll start to try to do it homeopathically. And then they'll have a huge heart attack. It's like, are you taking your Plavix? No, I stopped taking it, I'm doing it homeopathically. It's like, and they gotta go in and reopen the stent.
Oh,
That happens more often than you would believe. They just don't understand it. So cardiogenic shock, we do put on high flow too, because they need every bit of oxygen they can get. And we transport them as soon as possible and try to get advanced life support as soon as possible, because they can also be pacemakers, external pacing, which may help in that situation. Any questions? Now, if they're able to compensate for the left ventricle dying, which they might be able to for a while, they'll develop a condition that we went over in respiratory emergencies called congestive heart failure. This is when they compensate, kind of overcompensate. The blood pressure goes through the roof, they become tachycardic. The blood starts backing up into the lungs, because the left ventricle still can't pump it well enough. Then as the right side of the heart starts to fail because of that, then it starts backing up into the vena cava, which then backs up into your feet and into your jugular veins. So you end up with severe shortness of breath. They cough up pig frothy sputum because the blood that's backing up into the lungs. They have rails, hypertension, tachycardia, dyspnea, jugular vein distension, and pitting edema in the feet. Good news for that though is you guys have CPAP, which is the silver bullet in the field for immediate resolution. It's not a permanent solution. But you throw these people on CPAP, to turn the light switch on. We go from speaking one word sentences in respiratory to 40 to speaking whole sentences and go, wow, I feel 1,000,000 times better. It's just that pressure inside the chest pressures the vena cava, slows down the heart, gives it full oxygenation. It's amazing. Yes,
Where's the pressure in the chest?
from the CPAP, continuous positive
Oh.
pressure. Put that CPAP on, and it puts them above atmospheric pressure, so it opens the lungs up,
And it puts massive pressure, air pressure inside the lungs, which then squishes the heart, squishes the aorta, squishes the vena cava, so it can't pump that hard.
Okay. That's why if you put CPAP on someone with blood pressure of less than 100 systolic, it kills them. Don't ever do that. Any questions? Now here's something we hope you'll really like.
A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster and the ventricle may increase in size, becoming an even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
Any questions?
Oh, I did have a question on like
Yeah.
when the liver gets enlarged. I heard that you can palpate that in the field and see if that's like.
You're really, really good. I'm
Yeah.
not that good.
Okay,
I've been doing this for decades.
right. It's not like a common thing.
Just depends on the person and how soft their gut is. Like, I guarantee you, you can't palpate my liver.
Oh, okay.
But, yeah, sometimes you can.
That's not a reliable, like,
Oh, and it's not
Ruling
gonna
out.
really help you in your
Yeah.
cellular field.
Okay.
It's not. If their liver's that enlarged, that's a problem. They're gonna have yellow skin and their
okay,
splur's gonna be yellow, and
yeah,
that's gonna tell you more than the palpating the liver.
gotcha.
There's your signs and symptoms of CHF, you need to know that. There's an outside chance you guys might have to take a test this afternoon. Ooh, I- Telltale signs of congestive heart failure.
Why does the wet skin happen?
Oh, that's from the vasoconstriction. So when your fight or flight kicks in to increase your blood pressure and increase your pulse rate to fight for your life or run for your life, the byproduct of that adrenaline release from your adrenal glands is diaphoresis. And the reason why it gets cold is because it shunts the blood away from the skin. So there's no blood in the skin, so that's why it's cold. Okay. And pale, because there's no power. Any questions on signs and symptoms of congestive heart failure? Jugular vein distension. See the jugular veins. My kids were little, I used to bring them, put them underneath the overhead projector, and hold them upside down so you could see it. But they're all adults now, and I'm not that strong. So, and I don't even think we have it overhead. Oh, yeah, we did. It was small. Just kidding. The treatment, CPAP is amazing. If they have their own nitro, you can get a base hospital physician order to assist them with their nitro. Assist them with some nitro before you put them on CPAP. Nitroglycerin smooth muscle relaxer will do the same thing. It'll dilate those arteries, which will take drop the blood pressure, make them breathe easier. Works with the CPAP very well. Questions? Advanced life support also is good for this because they can give nitroglycerin without an order. They can just give the standing orders for it.
It's the frothy stuff. This stuff or
That is, so you get the big frothy stuff, because yeah, that's from the fluid, the blood backing up from the left atrium into the lungs through the pulmonary vein. It's not fun. All right, that brings us to hypertensive emergencies. This is when people's blood pressure skyrockets. It can cause them to have bleeds inside their brain, which we call a hemorrhagic stroke. It can also cause the aorta to tear under the high pressure. Cause the aortic aneurysms. You really don't want that because that kills people very quickly.
Does the current market volatility and inflation have you concerned about running out of money in retirement? Will you?
Thank you for the word from our sponsors.
Blood pressure is the force the circulating blood exerts on the walls of blood vessels. It is different in different types of vessels, but the term blood pressure, when not specified otherwise, refers to arterial pressure in the systemic circulation. When the heart contracts and pumps blood into the aorta during systole, the aortic pressure rises, and so does the systemic arterial pressure. The maximum pressure following an ejection is called the systolic pressure. In between heartbeats, when the ventricles refill, blood pressure falls to its lowest value called the diastolic pressure. These are the two numbers on a blood pressure reading. Blood pressure normally shows a daily pattern and is usually lower at night. During daytime, it fluctuates with physical activities and emotional states. Hypertension refers to a persistent high blood pressure. In the US, high blood pressure used to be defined as greater than 140/90, but recent guidelines have changed these values to 130/80 to better prevent and treat the condition. Normal blood pressure is below 120/80. In practice, blood pressure is considered too low only if it produces symptoms. Hypertension does not cause symptoms on its own, but it slowly damages blood vessels, and in the long term is a major risk factor for a variety of cardiovascular diseases such as stroke, aneurysm, and heart attack, as well as end organ damage such as renal failure or vision loss. For this reason, hypertension is known as the silent killer. Hypertension can be classified as primary or secondary, with the former being responsible for over 90% of cases. Primary hypertension has no apparent cause and may develop as a result of old age, obesity, high salt diet, lack of exercise, smoking, and drinking. Most commonly, the blood vessels are hardened with age or unhealthy diets, making it harder for blood to flow. Secondary hypertension, on the other hand, is caused by an underlying condition. Many conditions and factors can cause hypertension. Most notable are kidney problems and endocrine disturbances. Regardless of the cause, the increase in blood pressure is produced by either an increase in vascular resistance, narrower or stiffer blood vessels, or an increase in cardiac output, larger volume of blood pumped out by the heart. These two factors are the targets of antihypertensive drugs. Treatments must start with lifestyle changes such as healthy, low-sodium diets, physical exercise, and stress management. On top of that, antihypertensive agents may be used to control hypertension. These include vasodilators. These drugs dilate blood vessels, thereby decreasing vascular resistance and reducing blood pressure. Diuretics. Diuretics promote sodium and water removal by the kidneys and thereby decrease blood volume. Drugs that decrease cardiac output by decreasing heart rate or contractility may also be used to treat hypertension.
Any questions? So anyone that's ever seen a garden hose or a fire hose start to blow knows what an aneurysm looks like. The weakening of the wall of the hose. The muscles are no different than a garden hose or a fire hose in that circumstance. You get this big bubble on the edge of it, which of course doesn't bother you until it ruptures, then you get a big problem. Any questions? So they can now do, we used to have to do, surgeons used to have to have Wraps on the end, you have some like aorta around here. Now they can do an internal sleeve going up here.
Is there any way to view those in advance of a rupture, like on a imaging?
X-ray, yeah, they can do a CAT scan,
Okay.
MRIs.
The aorta is the largest artery in your body. Your heart pumps fresh, oxygen-rich blood through your aorta to deliver oxygen and nutrients to all your organs and tissues. Your aorta is divided into two main sections, the thoracic aorta and the abdominal aorta. The thoracic aorta has four parts: the aortic root, ascending aorta, aortic arch, and descending aorta. The wall of your aorta is composed of three layers that give it strength: the intima, or inner layer, the media, or middle layer, and the adventitia, or outer layer. The elastic muscular media prevents your blood pressure from rupturing the wall. Over time, degenerative disease may cause the media layer to break down, weakening the wall of your aorta. Blood pumping against the weakened area may cause it to bulge outward like a balloon. When this condition occurs in your chest, it is called a thoracic aortic aneurysm. These aneurysms may occur in one of several places, including the aortic root, the ascending aorta, or the descending aorta. Most thoracic aneurysms have no symptoms. However, when they reach larger sizes, various symptoms may appear, depending on the severity and location of the aneurysm. Symptoms of stable thoracic aneurysms may include shortness of breath, chest, back, or abdominal pain, difficulty swallowing, and hoarseness. If the aneurysm ruptures or dissects, more dramatic symptoms will appear, including a ripping sensation in the chest, severe pain in the back between the shoulder blades, dizziness, and difficulty walking and speaking. If you have these symptoms, you should seek immediate medical attention, as this condition is life-threatening.
You think?
Blood pumping against weakened aortic walls can lead to another life-threatening condition called aortic dissection, which may or may not occur within an aneurysm. Most commonly, aortic dissection begins with damage to the intima layer. Blood moves through the break in the intima, separating it from the media, causing bleeding inside the wall of your aorta. As a result, a flap called a septum forms between the true aortic channel and the false channel. From here, the blood may break through the outer layer of the aortic wall, causing an immediate life-threatening condition, or it may re-enter the aorta through another tear in the intima. Over time, a blood clot may form in the false channel. An aortic dissection may be classified according to its location and duration of symptoms. In the Stanford system, if you have an aortic dissection in your ascending aorta, it is called a type A dissection. All other dissections are called type B. The most common symptom of thoracic aortic dissection is sharp or stabbing chest pain, usually sudden and severe. If you have a type A dissection, you're most likely to feel pain in your chest. If you have a type B dissection, you are more likely to feel pain in your back than your chest. If you have these symptoms, you should seek immediate medical attention, as this condition can be life-threatening.
I wouldn't have taken 5 caffeine pills every day, but like everyone around me, I was consuming the same amount, but it was in disguise. And I felt like shit. I'm a dad and CEO of Mudwater. I started my career as a designer, working for a bunch of different tech companies. And like many, fell into the hustle culture, sleep when you're dead trap.
That was uncomfortable. Boy, was that like targeted towards me or what? That makes me feel eerie.
Have you tried bug water?
No. Now I don't want to, that completely just creeped me out.
Personally attacked.
Yeah, totally, it's like. Right thing. Alright, signs and symptoms of aortic aneurysm. You're gonna feel a sharp pain. A lot of times what they'll tell you is it feels like someone's putting a sword straight through their chest or in an abdominal and straight through their abdomen, radiating through their back. Late signs of it, when they're already way behind the 8 ball, if you expose the back, you'll actually see a demarcation line, everything will be pale and modeled below that. And of course, you'll lose pedal pulses, because there's no more blood going down there, it's all starting to pull into your abdomen and into your chest.
So it's like, they feel like there's a sword through their back, loss of pedal pulses and a line of demarcation.
And late sign demarcation, they're probably gonna die by the time you see that.
Okay,
They're in big trouble if we got a line of demarcation.
and that's just a big line of,
Yeah, well, like we showed, like that guy that had the, post go through his groin. And you could see where the femoral artery was compromised, you remember that picture?
no.
In the pier.
Yeah, I don't think I was there that night.
Yeah, it was a guy on a jet ski that crashed into a pier. And one of the posts of the pier went straight through his groin and came out his back. And you could see the line of demarcation where it completely severed his femoral artery. They were actually able to reproduce it, save the life, pretty amazing. But yeah, demarcation line, everything will be purple below that, or just completely pale, because there's no blood.
Okay.
So it's a line where you have perfusion above the line and no perfusion below the line. Now, let me show you a picture of that.
When I went to ride along with John Shasta ambulance, one of the first things that almost all of the paramedics said were like, "Oh, have you seen Pole Guy yet?" And I was like, "What?" And they were like, "Pole Guy, the guy with the pole through it." And I was like, "Oh my God, yes, I know what you're talking about." And Bryce was like, "Yeah, I'll just go down the street sometime and be like, hey, have you seen Pole Guy?" And I'm like, "Bryce, you should do that."
I'm glad I've provided so many people with that experience.
Yeah.
Talent thoracic deployment. This
Before you
animation,
feel on this,
it
this
is
shows you what
important
they
to
can
first
do.
locate the
With,
radial cake markers on the talent
They don't have
thoracic
to
stent
split your
track
chest
to
up and
identify
slice
the
your aorta
location of the
anymore.
connecting bar external slider counterclockwise.
They just put in a sleeve
Withdraw the
inside your
graft cover
artery.
until the
pull the
proximal
sleeve
bear
down,
spring
cut
and
it
the
off,
next
leave it.
covered spring have been deployed. Make sure that only the first 2 springs are deployed before verifying the position.
This is a
Perform
training video for
angiography to
surgeons.
verify
You
the
guys know.
position of the stent graft in relation to the delivery system. Depress the button on the quick
That's what they
disconnect to retract.
Any questions? Yes.
And just to clarify, the paramedics aren't doing any of the catheter
Oh, gosh.
stuffing. I didn't think so. Okay,
No.
you're just like,
You gotta be in a cardiac surgical facility.
gotcha, cool. So now.
And in fact, things like that, they don't even do in Reading and Medford that I know of. You gotta go to like Stanford, UC Davis, it's
Oh,
usually
yeah.
university level stuff.
Jeez.
Yeah. All right, you've been dispatched to a possible heart attack at a residential or a small town. What do we do first? Seat size up. Everyone's got their BSI on. Nature of illness is chest pain. You don't need additional resources. There's no indication of C-spine. What's next? Primary assessment. You got a mid-50s male, left lateral coming on the couch. He's alert. Complaining chest pain. He's got a strong radial pulse. Everybody's clear. He's breathing adequately. You put him on 2 liters fluid of O2, but it's cannula, not high flow 2. And he's pale, cool, and wet with chest pain. Is he a priority patient?
Heck yeah.
What's next?
Secondary assessment.
Sample with?
OPQRS.
Yes. OPQRST is going to be critically important in identifying our symptoms. So, signs and symptoms, chest pain, let's define those symptoms. Onset, he awoke with pain at 07:30, provoked while awakening. Quality, it's a crushing pain. Radiates to his left arm, his jaw, severity is 9/10. in times, is it consistent or episodic? It's been consistent for 8 hours now. Now, so that gives us a whole better picture of the signs and symptoms, doesn't it?
Mhm.
All right, allergies, allergic to Advil, Medicaid, lisinopril, and metformin. Those are diabetic, metformin's diabetic, type 2 diabetic medication, lisinopril for high blood pressure. Past with a history, high blood pressure, non-insulin dependent diabetes, that's type 2 diabetes. Events leading up to it, he woke up with his chest pain. It gives you a pretty good picture, doesn't it? Well, what's going on? What's next? Secondary. Blood pressure 160/94, that's too high. Heart rate's 108, that's too high. Respirations are 20, that's high. His eyes are open, it's already 10/20, obese demands. What's his GCS?
15.
15. Everything's negative on the physical exam. This is a total sample thing, giving us what we need. What do we do? O2, get transport, ALS rendezvous as soon as possible.
All right, so majority of this class, you guys will see videos on what not to do and how terrifying real EMS is. This is one of those rare videos that you'll find out there where things actually go right. Their field party. Here, this is the video.
Lifeguards respond to a cry for help.
This is exactly how it should go.
Lifeguards bring the unconscious man to shore with the help of Good Samaritans. First thing to do is bring him all the way out of the water, try to keep him dry. As one lifeguard stays with the victim, lifeguard Gillis rushes for his medical kit. Each passing second could be the difference between life and death. Additional lifeguards come to the aid of the victim. They quickly work to assess the man's condition. The man is not breathing. Lifeguard Gillis tries to clear his airway.
Whereas an unresponsive patient who is not breathing or not breathing adequately.
An ambulance is on the way, but if lifeguards can't expel the water from his lungs, it may be too late.
We need to get oxygen in him as soon as possible so we can bring him back.
Coming up, back in Waikiki, lifeguards work furiously to revive the elderly drowning victim who is still not breathing on his own. They use a BPM device to get desperately needed oxygen into his lungs.
And we use that on unconscious victims that we're usually doing up there late in the day.
The man is still not responding, and his vital signs are fading fast.
We're trying to breathe for the patient, and it's basically one breath every 3 to 5 seconds. The patient has a pulse, so we're not doing compressions, but we're just basically breathing for them.
The victim has been unresponsive for more than 7 minutes. His chances of survival fade with every passing second.
Hey, buddy, can you hear us? Can you squeeze my hand? You know this person, man?
Lieutenant James Sloan races to the scene and finds the dire situation unfolding. Honolulu's fire department corresponds with the lifeguards. The victim is still unresponsive when suddenly. The man is now breathing, but his respiration is weak and shallow. The situation remains grim.
Grace, let's put him back down on his backboard. Back down on the backboard. Back down on the backboard.
The victim is placed onto a backboard for immediate transport to the waiting ambulance. As lifeguards try to communicate with the man, an hysterical relative threatens to derail the rescue effort.
It's gonna be okay, man. Come. He's okay. Hey, look, he's okay, okay? He's breathing. Wait, come on.
The woman may hold vital information that could save the victim's life, but her broken English has lifeguards struggling to understand her.
Does he have any medical conditions that we should know about?
Extreme heart trouble could cause him to go into cardiac arrest. Time is running out. Lifeguards must quickly transport the man off the beach to a waiting ambulance for advanced life-saving techniques.
His condition, as far as health wise, he's probably not the best, but he's looking pretty good at this time. This patient been alone and rougher water. My guess is that he would not have survived. The patient, when he left, had a bolus and was breathing, so it's always good nature.
Yeah, straight to the ambulance, load, leave. Never a reason to have an ambulance sitting on scene with a patient in it. The idea of ambulance, it's got these things on, they're called wheels. So the patient's inside the ambulance, the wheels should be moving. They shouldn't be doing, oh, I'm gonna do all these skills and stuff. No, move. You do the skills while you're moving. Any questions? All right, aspirin. Aspirin is a wonder drug. It's a miracle drug. Does lots of things. The biggest thing it does is it's an antiplatelet, it's an anti-clot. And it will break up the clots that are on their way to making a heart attack bigger and stop blocking more of those coronary arteries. So if you give a patient aspirin immediately, you can stop more clots blocking more of the coronary arteries and the heart attack increasing. Any questions? Critically important drug. Nitroglycerin. Now you won't have nitroglycerin in your scope of practice, I can guarantee you that. But if a patient has nitroglycerin, you can get a base-off physician order under the right circumstances to assist them with taking it. Nitroglycerin is a smooth muscle relaxer. Your coronary arteries are smooth muscles. So when they relax, they dilate. So then more oxygenated blood gets through to the heart. So an angina, that helps. In a heart attack, it doesn't do anything because there's a clot blocking the artery, so dilating it will not help. Now, some things to know about nitroglycerin though. It is not prejudice. It does not only dilate the coronary arteries, it dilates every artery in your body, so it rapidly drops your blood pressure. So if they're sitting on a bar stool or standing on the edge of a road, or standing up anywhere, you don't give anyone nitro. They have to be sitting down in a safe spot. There's a good chance it's gonna obstruct blood flow to the brain from dropping the blood pressure too quickly and they're gonna pass out. Good news is nitroglycerin only lasts for 5 minutes and then it wears off. So if you just lay them supine, generally the blood will go back to their brain and they'll wake up. Don't freak out. And it'll wear off in 5 minutes anyway. Yes.
You get calls for people who are taking more medicine and then pass out?
All the time. All the time. And people that take nitro because they have a headache, people that take nitro because they think it's a painkiller, because they take it for chest pain, they haven't got the education of what it does. So they have pain for something else, they think it's a painkiller, so they take nitro for pain, then they pass out. Or they give nitro to a friend with pain that doesn't have a prescription for it in the first place. You'd be amazed. I actually had a physician once went and borrowed nitro from one of his other patients to give to someone who wasn't his patient, who was having chest pains in a parking lot. And the guy syncope fell between 2 parked cars. Was wedged between the 2 parked cars. Never give it to anyone with systolic blood pressure of less than 100. Never give it to anyone with a head injury or has signs and symptoms of a stroke. And the big thing is, do not give nitroglycerin to anyone that has taken sexually enhancing drugs in the last 24 hours. Why is that? So the reason why Viagra was invented was not to be a sexually enhancing drug. It was actually invented to replace nitroglycerin as a long-term vasodilator. It does the same thing as nitroglycerin, but it does it over a long period of time. Found out it didn't really work that well for angina and things like that, but they did find, they got a big surprise, and found out that it worked on other things. And found out they could make 50 times more money selling it as an erectile dysfunction drug than as a cardiac drug. However, if you give that with nitroglycerin together, they potentiate. What potentiation means is 1 + 1 = 5, doesn't equal 2. In other words, kind of like two bad teenagers. You put a teenager here that's a problem and this one problem, you put them together one night and you've got chaos and mayhem everywhere. Well, that's what nitroglycerin and Viagra do together. It will cause life-threatening fatal blood pressure drop. And you won't get it back. So do not give this to someone that has or has taken sexually enhancing drugs.
If somebody's taken the Viagra within the past 24 hours and they're nitroglycerin before
You're gonna die. Yes.
So taking a vasoconstricting medication or giving that to a patient after they've maybe accidentally taken both their Viagra and the nitro, that wouldn't somehow.
That's
like,
highly
counteract it?
dangerous.
So that's even more dangerous.
Well, that's what they, actually, that is what they do. So
Okay.
have you ever seen the commercials for ED drugs?
Yeah.
In the small print buzzes, if you have an erection lasting more than 4 hours, please consult the physician. And you know what the physician does is they will actually take epinephrine, which is a vasoconstrictor.
Right.
And they will literally inject it into the penis to get the vasoconstriction to get it to go back down.
Wow.
But only a doctor should be doing that. Nobody should be doing that themselves. And of course, vasoconstriction in a heart attack is the last thing we want.
Right.
So that gets complicated. Any questions? Everybody ever seen Meet the Parents? We gotta do that? All right. Nitroglycerin, so believe it or not, nitroglycerin, the medication, is the same nitroglycerin they put in dynamite. You soak nitroglycerin with sawdust and wrap it up in paper, that's what dynamite is. This is just a much smaller dose.
So if you ever have a patient you really don't want to treat, you can do that.
Well, the big thing is, if you give someone nitro, don't drop them, so it'll explode.
Okay.
It's like 1/1,000,000th the dose of dynamite nitroglycerin. But it is the same exact nitroglycerin.
Oh, that's crazy, actually.
It is crazy.
Yeah. Right.
Who came up with it?
I have no idea.
I know, who was the dummy that was like, let me eat the explosive and see what happens?
No, what happened was it was a pioneer that was sent to blast a mine. He'd been having chest pain all day and he got the nitroglycerin from old dynamite on his hands and then he felt better and that's how they discovered it. I have no idea if that's true. I just made it up. Maybe I'll spread that one around, see how far it can go. Throw it out on social media.
Comes back to you next year. when
No.
the students-
No, you can't spread it on social media, everyone would believe that.
Yeah.
Yeah, well, even before social media, I got in trouble here because I used to make a joke in the beginning of class that with a nasopharyngeal airway, if you don't have Vaseline, you can use the patient's saliva. So I used to drop the word patient. I said, you can use saliva. I take it, I go like that. Well, apparently, not for my chest ambulance, but another ambulance in the county, a EMT that had taken my class, took a nasopharyngeal and put it in their mouth and then spit on it and then shoved it up the patient's nose. Yeah,
Oh, that
Somehow
that must have been one smart cookie.
somehow I didn't get fired.
Just a real smart person.
Yeah, I made a lot of mistakes teaching stuff.
41 semesters.
I learned from them and I didn't do it again. Same thing with estimated blood loss, so I said, put some food dye in it, they'll throw it on somebody. And if someone actually did it, then their parents complained. College.
I didn't say that was a-
I don't know how I still work here, but it's still working, so. Anyway. Moving forward.
Because I don't think I'll forget any of the nitro stuff you just talked about. That was funny as hell.
Yeah, well. And they actually just down in Backville where they make Viagra at Gentech, they just had 2 truckloads stolen. They had no reason. think it was probably hardened criminals.
Oh.
All right. So. Stereotypical picture of a guy that's probably taking ED drugs. Just kidding.
Oh, it's his glasses.
Always take, because they have glasses, they take ED drugs.
No, I have the same glasses as
Oh.
that guy.
Okay. So anyway, always take their blood pressure before and after giving any medication, but especially nitroglycerin. Make sure they're in a position that they're not going to fall and hurt themselves if they sick of these. Any questions? Bless you. Everything about this one, obviously, the fire department, the lady works for does not have a 3 at 50 policy. Well, the CDF guys are going. All right, so assistant nitroglycerin, make sure you have your 5 R's and learn about pharmaceuticals. And make sure that you have contact and gotten a base hospital physician order before you do it. Any questions? Do not give this to people just because they have high blood pressure. You never give it to someone with signs of a stroke. Stroke first. You're gonna put it under their tongue. Way that you'll know it's working is 1, to get relief of the symptoms of angina, or 2, they'll feel a burning sensation of their tongue and generally also get a headache. This does cause a headache. Any questions? It's only gonna last about 5 minutes. Wears off. Any questions? All right, yes.
If it wears off in 5 minutes, can we give it every 5 minutes? Or
Yes.
Okay.
Generally, that it depends on what the order you're given. The physician says you give it every 5 minutes up to 3 times, or every 5 minutes as long as their blood pressure stays above 100. Okay. But generally, if it's angina with rest, you shouldn't need more than 3 of them with rest. If it's still going past 3, you've got a real big. That's what they generally teach people if they give you the proper education. They'll tell cardiac patients, if you're taking your 3rd nitro, you're still having chest discomfort, call 9. So some people that have been resuscitated from sudden cardiac arrest from ventricular fibrillation, they'll put in a it's a smart board. It's a board that's smarter than I am. Anyway, they'll put in pacemakers and or AEDs inside, or internal defibrillators inside the patient. They'll monitor their heart rhythm constantly. If they get too bradycardic, they'll start pacing for them. And if they go into a cardiac arrest of BFib, it'll shock for them. They'll have electrodes directly on the tissue of the heart, which is pretty cool. So if they have these, usually they'll have a little box underneath the skin, underneath their left clavicle. Do not put an AED patch over that. The AED patch should be here and here anyway. So I don't know how someone would do that, but apparently it's been done. And it has very bad results. All right, AEDs, we've taught you guys a lot about AEDs, but we're gonna go over it again, just for review. So automatic external defibrillator, you not put these on people that are alive just in case they go to cardiac arrest. We only put these on dead people. And then you have to stop and make sure they're not moving to analyze the rhythm. Any questions? If it analyzes a shock, it will shock, yes.
Does that also mean like if we're in the back of an ambulance and we have Nate hooked up that with the ambulance moving, it won't
Yeah,
work?
it's supposed to stop technically. I don't know if anybody really does that.
So you can still use it while it's moving, or you're
not supposed to. Okay. But is it realistic to pull over and stop every 2 minutes when you finish your CPR? That's why you generally don't do CPR in a moving ambulance. You can go back to CPR while you're moving in an ambulance. Yeah, most will do what's called grab rail CPR, the grab rail from the ceiling, hold the grab rail, which is highly ineffective. No one survives that. That's why I say don't transport unless you have the cap to CPR. Question?
Is that the piston thing, like the mechanical seat?
Yeah, one the piston, the ones we use around here are actually called load distributing bandit squeezes, teaser
Oh.
squeezer.
Oh, okay.
Yeah. It's,
You guys have them on the.
yeah,
stuff up
every
there?
ambulance and most fire departments are having that too. At least in South County. We've done a pretty good job going over the electrophysiology of the heart. Any questions on that? Already went over that. Any questions about your PQRST on your cardiac rhythm? Preventricular contractions, that's, remember we talked about that, it's the one rogue cell that's not getting enough oxygen. So it's backfiring and the blood doesn't flow, so it causes ventricular pulse. There's too many of them do it. That's what causes ventricular fibrillation, causes the all bar fight in the spleen. So that's when you got more than one of them, multiple PVCs. Then it leads to ventricular fibrillation. That's where the defibrillator comes in. It's the sheriff shooting a gun through the roof of the saloon, get everybody to shut up, take over. Any questions? Defibrillation is depolarization of the entire heart. You get the SA node, natural pacemaker, a chance to take over again as the leader. Questions? It's like rebooting yourself up. That's what it'll look like if you have one monitor. See what's going on.
So, oh yeah, one thing I was confused about, on ventricular fibrillation, is that something that like is an acute onset thing, or is it something that happens over like, somebody has an irregular pulse for a while and then suddenly becomes a problem?
Yeah, generally, it only becomes a problem when the PVC comes during repolarization during the T waves.
Okay,
They call it an R on T phenomenon, because the PVC is still a QRS, but it's a QRS firing backwards. And when it fires at the same time as the T and the R hits the T, then it goes into VFib. And then everybody just starts going crazy.
so can someone have ventricular fibrillation for like years and then it's
No.
becomes an issue? Or it's-
Ventricular fibrillation is instant death.
Oh, so that's the instant where it actually starts becoming, gotcha.
Atrial fibrillation they can have for years.
Oh,
But
gotcha.
ventricular fibrillation, you'll have no blood pump. It's death.
Gotcha, okay.
It's like yelling fire in a theater. Everybody's like, ah, you're all running. And somebody says, shut up, everybody. And then they take over again. Everybody sits back down in their seats. That's what that is.
Gotcha.
Any questions? What? Did I just confuse you?
No. I need to go over it like 5 more times.
I'm gonna start drawing cartoons on this stuff. Explaining with cartoons. Said they can't draw. Huh?
It's up. I don't know, I think
I think you can explain everything with cartoons. They're much more fun to watch. All right, unwitnessed arrest. Don't worry about that. That's old. Don't put defibrillators on people with a pulse. There's case histories of people putting defibrillators on people because they thought they were going to arrest, and then they syncope like nitro. Then they shock someone that still has a pulse, which is very bad, and send them into cardiac arrest. So don't ever do that. Don't be that ESP. They'll have to have quality control. Someone needs to be reviewing every time it's used to make sure it's used correctly. Here's another good one. This is some Aussie lifeguards. This is in Australia, so the PQRST is backwards, it's upside down because it's on the other side of the world, so the polar is reversed. Just kidding, that's not true.
You get time first in Australia.
Huh?
You get time first in Australia.
Yeah, well, actually, you put the 80s on backwards. It's got a shot, the poles are opposite. Just kidding, don't do that. That's totally not true.
If an Australian is here.
1 p.m. midweek on Bondi Beach. A small crowd, gentle surf,
Good job.
perfect conditions.
So, it's also pretty old video, this old CPR, it still worked. We do not use CPR this way anymore. It's very slow CPR. They found better ways of doing it, so don't use that as an example of how to do CPR.
Sensational. It's not the time when you expect things to go wrong. 5 off-duty lifeguards happen to be taking part in a photo shoot following media interest in Bondi rescue. Amongst them is Hoppo, the boss, and Corey, one of the most experienced lifeguards on the beach. Halfway through the shoot, a dramatic event unfolds right beside them. A man's found floating, lifeless in the surf. His name is Takahiro Ono, an English language student from Tokyo. No one knows what's happened to him or how long he's been in the water.
Right, someone go and get on the radio. This radio on my bike, confidence fit.
Hoppo can't detect a pulse.
Baggy, come on.
He's not breathing.
Baggy, come on. Baggy.
Tucker is clinically dead.
You grab the mum?
The boys must get his heart beating again and air into his lungs.
It's a male, about 20 years old. Put him on the bag now, I'll get back to you in the morning. Okay.
Danny arrives with the defibrillator as Corey starts CPR.
1, 2, 3, 4, 6, 7, 8, 9, 10, 11.
Tucker still has no pulse.
Stay clear, stay clear. Yeah. Come on, stay clear. Stay clear. Ready?
The machine reads Tucker's vital signs.
Check pulse. Good pulse. Check pulse. CPR. I can't get one. Start CPR.
The defib doesn't work on Tucker first time. The machine needs time to recharge. Corey continues CPR.
11, 12. Yeah, copy that, Chapo. 12, 13, 14, 15.
It's 4 minutes since lifeguards got to Tucker.
1, 2, 3, 4, 5, 6, 7, 8.
The machine needs time to establish whether he has any heart rhythm. Tucker's had 2 shocks. He's in spasm. Patients rarely survive if they need more than 3 shocks. Tucker's been clinically dead for at least 4.5 minutes. He has 1 chance left.
I've lost it. Stay clear, stay clear, stay clear.
The 3rd shock has finally had an effect.
Analyzing rhythm. I want shock again. Come on, breathe. Still staying good. Stay clear, stay clear. Analyzing rhythm. So much. CPR. It's getting stronger. Take good pulse, pulse here. You've been in the water, and you swallow a lot of water, okay? Stay, just relax, mate, just relax. We're looking after you, okay? Understand? It's got a strong heartbeat now, strong heart. Just keep your head there, mate, it's okay. Just give you some oxygen. It's okay, it's okay. It's okay, mate, just relax, just take it easy. Good work, boys, all of you say good work. 5 deep breaths, mate, okay?
That was a good job. There's another one in Huntington. This one takes a lot longer. They actually get paramedics involved.
A man collapsed on the boardwalk, lifeless. They have mere minutes to save his life. If he's not breathing, it increases chances that he'll have severe brain damage. So there's your situation, somebody that's obviously unconscious, also stresses. The man's son-in-law tries to provide clues to what caused the collapse.
They were taking a rest from the ground, sitting on the ground, and just went unconscious.
Lifeguards ready the AED. It could be the difference between life and death.
The key to saving people that are having heart attacks is early defibrillation. The AED runs an analysis and basically tells you whether the patient has a shock or rhythm.
Shock failed to restart his heart. Here's the bilateral breathing. Wake up. Those aren't actual breaths, it's just noises coming out of the windpipes. The patient is not actually breathing on their own. The man's chances of survival decrease with every passing second. Time is running out. Paramedics have joined the efforts to save the life of the man in cardiac arrest.
He was unconscious, unresponsive. The patient is still pulseless, breathless, receiving respirations, via back mask, and chest compressions. Still not very good skin color, but we're doing all we can.
The victim's anxious son-in-law attempts to reach family members who know the man's medical history. Any information could help the rescue team in this perilous situation. Paramedics administer drugs that could reset the man's heart.
It looks like he just got one breath.
But the drugs have no effect. Again, his body reacts, but his heart does not.
It appears at this time that he is essentially dead. He's not ready, and his heart is not working on its own. The challenge here is to get him back.
Precious seconds continue to pass as the man remains lifeless.
Shots are made after 3 shots. Usually different. Healthy or strong. They're going to pretty quick. And we got something we can show.
Have delivered several shots. Performed CPR and injected medications to the man in cardiac arrest with no success. When suddenly, the man's heart restarts. The man is in need of advanced medical care. Still unconscious, but now has a strong pulse.
Continue to do everything we can to get him back.
The endless effort of lifeguards and paramedics has resulted in a miraculous recovery.
But they didn't get him back, so I'm not gonna argue it's success.
Well, it was probably pretty good.
Probably, but they at least gave him a chance. All right. You guys wanna take a 10-minute break, come back and do neurological emergencies?
Woohoo.
10 minutes. Right. What's that? Watch this. I think it was 480.
I'm being charged over $1,000 for one class.
No.
Okay.
Yeah,
Who do I go to talk to people about
With
that?
good administration, Monday to Friday. You have past, past fees that you didn't pay, probably. How much is the California Community College credit? Something else. Actually, effective summer 2022, $290 per unit. 6-unit class would be $1,500.
Really? Cause I went to the counseling last semester, they said it's like 50 something.
Yeah. Yeah, same here now. Out of state, I thought it was on $50 too.
I always paid like 3 something for this class.
Out of state. You must have a pass. I was like, both my daughters have a pass due for like credits from their previous classes they did. So what I would do is go to admissions. It's on my day. Tomorrow. Got somebody that should be able to answer. Michael Kelly, one of my students. That I did name. I'm sick of the child. Yeah, it should have only cost you about $350, like six units at $50 a unit, plus the materials fee, which is around $30. So. But yeah, it shouldn't be $1,000. I don't know why this, when I Googled it, said that, but it seems. That is just Mississippi, Speed, California.
We literally cause it.
Oh, here it is, right here, $46 per unit.
Yeah.
So it should be right at $300.
I was gonna say, yes, you can.
It's only $184 if you're
At least,
out of state.
it's free. Only how much? What?
It's $184 you're out of state, but $46 for California residents. Yeah.
I called the registration.
Called who for registration? Oh, emergency department?
And they said, call during the week, I thought it was 24/7.
Yeah, but I don't think that their weekend clerks are as well trained as their during the week clerks or regular people. Staffing things post-COVID 24/7 with qualified people is really challenging. So you're probably better off calling during the week where the long-term employees that know what's going on are working. People on the weekends are probably the newest people that are kind of like wandering around going. No different than an ambulance or fire department, the new people start on the nights and weekends. Unless you're on a platoon schedule, then it's easy for everybody.
I'm not sure what this is.
Do we have any questions? Already killed 2 hours this morning
When are we taking the weekend?
after lunch,
Which is one.
which is after neurological emergencies.
What, one?
What goes how fast we get to neurological emergencies?
I'm like losing information.
Did you put your book under your pillow last night like I told you to?
What?
Yeah, then osmosis goes through your ear as you're sleeping.
That just gives you a kink in the
school
neck.
is too thick.
Huh? She's got a hole in her skull right here. It's called a cancer. It seeps through the ear.
Goes out the other.
The audio books while you sleep does actually work though. It does help.
I think my kids watch that. Exactly.
You play the patient assessment video over and over and over. You put it on a loop while you sleep.
I'll still forget to marry the head.
Huh?
I'll still forget to marry the head.
I'll be like, you might not really draw. You were also. Not anymore.
What do you think? I'd be interested to know where
Everybody says I'm better. Cheers. Cheers, Johnson.
And I was running.
Most of the other plans, of course.
Yeah, I went back and I don't know,
I didn't either until I took this class. I said, wow,
You're good.
how cool is that? You're gonna finish your midterm and then you have to prepare. Somebody did yesterday at 7 minutes. So the record for perfect score before we required the 6 foot ball set was 4 minutes. That was during auto education. They don't give it auto no missed points, no fail.
We have lunch before the midterms? Yeah.
Yeah, I want you guys to have good glucose scores.
Yeah. I kind of mixed it.
No, that though, high calorie, high fat, would be tired. I was tired.
Yesterday I got a normal.
Oh, yeah.
Downtown, Lexus on South. So right before the arch on the left, across from like Shell Station.
I wish I could find the. Life expectancy probably would be too long as a battery frequency, but.
Same with Chaz, but or 7 Sun, it's sitting just so hard.
There's always people standing outside. Yes. So.
Yeah, when Max first opened it, morning, go in there and just finally woke up. Something and then it's out more popular.
Well, because of that building. It's so unique. It used to make the best house.
Oh, the old geckos?
Yeah, geckos.
I don't know how long.
Oh, okay.
That was a long time ago.
I took my time on it.
They made the biggest burritos and then.
There's only 4 hours on it.
I don't know, I always like Poncho Left to go to geckos.
I wasn't around.
That's amazing. It
Really,
takes like
Poncho
an hour and a
Left,
half.
still there.
Stay for 4 hours.
We should do it as an active.
Poncho Left is down by.
Oh, Ponchos.
Yeah, Ponchos.
I went straight across the street.
Oh, nice. We're in a marijuana shop?
I was there.
That's security.
And I can tell you one thing I learned from when we spent 3 years back here.
There's a paramedic.
Yeah. I just don't think it's still, it's like.
As long as you don't.
The exam 2 portion.
I mean.
I would imagine though, yeah, that's the chances of those places getting.
There's a water invitation.
Oh, yeah. People don't. California, man, everything's crazy.
I had to go through this packet. I wrote all of the SOCs. I had to go through the California packet, read all the standards. They were. Right, the guy will like send it in, get it replied.
And then what about cost? How much All right, here we go. Thoughts for the day. Best EMS people in the world. Can't do it alone. They have to have a team. You got to be able to cohesively work in a team in order to save a life. And your team is only going to be as strong as the weakest link on that team. So you can berate that weakest link and make them feel horrible, or you can work with that person to make them stronger and make your team the best it can possibly be. The choice is up to you and your team. The stronger your team is and the stronger the members are, the better the chances that you guys will be successful at saving a life. Questions? What?
Best friend team number 1.
But guess what? Tomorrow we have all new teams.
That's not what?
Times change, man. Life changes.
I like
You're
my
saying
team
we
too.
can't graduate and all get the same,
Orlando,
the exact same place?
Yeah.
Work the exact same shift every
Yeah.
single day.
It unfortunately just doesn't work that way.
Damn it.
You guys are like my other arm.
I like my team.
I feel lost without my yardstick.
You're gonna be in Oregon.
I don't know what to do without my yardstick. I feel like I'm done without a habit. Anyway,
You gotta help him out.
we're gonna learn about the neurological system. We're gonna learn about strokes. We're gonna learn about seizures. We're gonna learn about headaches. And we're gonna learn about what to do and how to assess them and what to do and how to treat them. And how to keep people from dying or being in nursing homes the rest of their lives. Because there's some real important things as EMTs you guys can do to complete reversal of strokes. Any questions? One thing we didn't go over cardiac emergencies is if a patient is too far away that's having a heart attack or a STEMI is too far away, they're not going to get to a cath lab in 90 minutes to have that artery opened up. One option they can do is go to an ER and get a clot busting drug called TPA or TNK. This takes a 2-page rule out list that they have to have negative on all full 2 pages of things to rule it out to make sure that they don't kill the patient. And even then, sometimes it will still kill them. But it will actually open the artery. It's a clot busting drug. And we're gonna learn about it because they use it for strokes too. But it's one of the most dangerous drugs on the planet. So it's kind of like, well, they're gonna die from the heart attack anyway. Let's at least give them a chance and try to dissolve the clot. So, anyway, we're gonna go over that.
Do you know like the statistics of how often it works compared to how often it kills them?
Oh, way above, works way more often than it kills them. But if gone properly, with the 2-page checkoff list is answered honestly, which most people don't answer honestly, and all the requirements are there and it's in the right situation, the benefit is way outweighs the risk, absolutely.
It kills people by making them just bleed out.
Dissolves any, like if you have unknown bleeds inside, what they call occult bleeds, they don't know that they're there, like GI or brain or anything like that, just little tiny bleeds, makes them big bleeds that kill you.
And then air resources in this county, like how
Don't exist.
They just don't exist. Okay.
They gotta come from Reading or Medford.
Okay.
And it's gotta be good weather, which eliminates half the days, and then it's gonna be about 45 minutes for them to get here. Cause you gotta call the dispatch center is usually in Oklahoma or Louisiana.
Yeah.
Then they gotta call out to the crew, then the crew's gotta go staff the ship, they gotta untie the helicopter, they gotta get it pulled out. They gotta warm it up, they gotta get it rotored up, so it's gonna take about 20 minutes to get off the ground, then it's about 25 minutes to fly here. And it's about another 5 to 10 minutes to take off altitude and land, then it's another 10 minutes to package them for flight. So now you're already at 80 minutes, it's only an hour drive to Reading or Medford.
Gotcha.
And you gotta fly 25 minutes back to one of those spots, so it's about 2 to 3 times longer to fly from here than it is to drive.
Perfect.
Do they at least put good tires on the ambulances?
Yeah.
Wow.
Yes, rotated every 3,000 miles, or every 5,000 miles.
That's pretty good.
Yeah.
I need to rotate my tires.
Yep, full servicing and rotation every 5,000 miles. All right. Any questions? Also, 7 of them here have automatic chains too, just click the button, click the switch, chains come down.
How does that work?
Huh?
How does
How does that work? There's a pneumatic pistons in front of the tires with the chains hanging. And so you click the switch, it turns an air compressor on, that charges the lines. And it brings the pistons down and it drops the chains in front of the tires. So the tires hit the chains, it self-propels the chains in front of the tires, so they always have traction. Then as soon as they get out of the area, they don't need the snow, they turn the compressor off, the pistons go back up into their home position.
And how does that take the chain with it? Cause is it like normal chains where they attach onto the tire
Yeah.
and spin?
They go in front of the tire, as the tire runs over the chains, it turns.
And they get tighter too.
Oh, okay, so like the chains,
Look them up.
okay.
It's very important.
Now we're going to lunch later, cause
Sorry.
Exactly, see, that would be smart if you went to YouTube and looked it up.
Hyundai Elantra versus Honda Civic.
Oh, yeah.
Look what Elantra has and what Civic.
The on-spot system allows the operator to engage and disengage tire chains at the flip of the dashboard switch to enhance traction and braking in forward or reverse without having to stop the vehicle. The system consists of 4 major components: the dashboard switch, the frame-mounted air electric solenoid, the on-spot chain unit assembly, and the vehicle mounting bracket. Whenever the driver needs the added traction or safety of chains, he simply flips a switch on the dashboard. Within seconds, the chain wheels come down and make contact with the vehicle.
That only works in about 6 inches of snow. If it's more than 6 inches of plowed snow, not gonna work.
It also seems like it would destroy the tires.
It doesn't seem to. We've had pretty good success with it.
That hard.
So, well, you're going at slow speed, you also can't drive over 25 miles per hour. So. All right, neurological system. Central nervous system consists of the brain and the spinal cord. Any questions? What's the Latin name for the brain stem?
I knew what it was.
All right, you're now the official water boy for the class.
I'm not good on the spot question. Found that out yesterday.
No alligators.
All said alligators have no clue how to that.
There's a map of the brain. All right, so the 3 parts of your central nervous system are the cerebrum, the cerebellum, and the spinal cord. And don't forget the medulla oblongata. Any questions? There's a cool picture in color of all the parts of the cerebrum. None of that's going to be on the test. I mean, you got to know the occipital lobes in the back. Things like that, but generally, you don't have to memorize that. So, the cerebrum is divided into the left hemisphere and the right hemisphere. The left hemisphere is on the left side, and the right hemisphere is on the right side. Yeah, you guys are lucky to have me as an instructor with my vast knowledge here. Now, cool thing though, is it cross wires to your central nervous system. So the left hemisphere controls the right motor side of the body, and the right hemisphere controls the left motor side of the body. How cool is that?
Did you know that dolphins, when they sleep half their brain at a time?
I did not.
Yeah, because they have to keep swimming, so they can breathe.
Yeah, because they're actually mammals.
There's my brain.
I watch Flipper as a kid, so that's very important. Most you probably didn't know who Flipper is. Alright. Then we have the cerebellum. It's a little golf ball sitting at the bottom of the brain. It's a squishy golf ball. Cerebellum has some real important functions though. That's why it's important that it doesn't die. Attention, language, emotion, fear, pleasure, motor function, all that stuff. Any questions about the cerebellum?
So when we're doing exams and
I don't understand the question. One more time.
during our assessments, we were
Uh-huh.
testing local consciousness and motor functions.
We're making sure that's intact and all the pathways to the ends are intact. Because it can have disruption anywhere from there to the ends of your system motor. Good question. Any other questions? There's that medulla oblongata. So that controls your breathing, your heart rate, your temperature. Not very important stuff, you know. Just kidding. It's very important. Any questions about the medulla oblongata? Don't be an alligator. So what type of neurological emergencies are you going to see as an EMT? Headaches are common. You're also going to see strokes, which unfortunately are too common. Seizures. And probably the number one medical call you'll respond to, altered mental status, which could be about 20 different causes. So let's start with headaches. A lot of different types of headaches and different pathogenic physiologies for each headache. They're usually not life-threatening, but they can be, especially if it's a hemorrhagic stroke. But the majority of the non-life-threatening headaches can be broken down into 3 different categories. That's migraines, tension, and clusters. Also known as sinus headaches. So migraine headaches are poorly understood. They still haven't figured them out. There's a lot of different causes and triggers. There is also a close relationship with seizures. They often see the same aura before a migraine that epileptics see before a seizure. They do know that it's caused by changes in blood vessel sizes inside the brain, but the triggers into why it happens is still not clear. Which is why they have still not come up with a consistent, good way to treat migraine headaches. Also, there's a lot of hormone based on it and dehydration, a lot of different things that can cause it. They can last for several days and cause visual changes, and they can be triggered by bright lights and strobes. Any questions? And aggravated with noise. All right, the most common type of headache, though, is the tension headache, which is generally not in the head at all. It's caused by muscle spasms in your neck and back, which then radiate pain to your head. And stress, especially cumulative stress. It's generally a squeeze, dull sensation. Relieved with relaxing the muscles of the back of your neck with either massage or muscle relaxations or removal of stressors. Any questions about tension headaches?
What might putting ice or something cold on the back of your neck would help?
It's a tension headache.
That makes sense.
It's exactly what that is. People from the cannabis place would say, just chill out. And sinus headaches. These things are brutal cluster headaches. These are people that have hay fever and they get congestion inside their sinuses that causes brutal focal pain, like in one spot. And it hurts like hell. I get these sometimes. Generally relieved with antihistamines. Any questions? Those are the three. They do move sometimes.
I had a horrible headache at work once, and this girl came up to me and like just pushed my
Change
forehead
pressure.
all the way down to my ears and down in my neck,
Acupressure.
and like, that's fine.
Yeah, she just pushed the
Amazing.
mucus and stuff because it's over,
It was insane,
thing of mucus.
but it didn't stay, it came back, so.
Right, because your body still produces mucus from the allergic reaction to whatever the hay fever is, whatever the trigger is. All right, so now there are also headaches that can be serious and life-threatening. One is a hemorrhagic stroke. Others are brain tumors and meningitis. Those will kill you. We're going to go over the signs and symptoms of that as opposed to the three common types of headaches. So you're able to decipher the difference as an EMT. So first of all, let's go over strokes. There's two different types of strokes. Your book in this slideshow might say there are three different types. That is not correct. There are two different types of strokes. Actually, there's three different types of strokes, but different than what we're talking about here. The two types of strokes are ischemic strokes and hemorrhagic strokes. 80% of strokes will be ischemic, 20% will be hemorrhagic. Or you can look at it as 4 out of every 5 will be ischemic, and 1 out of every 5 will be hemorrhagic. Okay? The ischemic stroke is when there's a disruption of blood flow to the brain. It's the exact same thing as a heart attack. A clot breaks off, blocks coronary, not a coronary artery, a cerebral artery, and everything distal to that clot dies. That's an ischemic stroke. A hemorrhagic stroke is when you have a brain aneurysm and it ruptures and you bleed inside the brain. Causes a stroke that way. That's a hemorrhagic stroke. The third type of stroke, which they really don't cover in here, is what's called a hypoxic stroke. The natural lack of oxygen from not breathing or being get to on. And then you got resuscitated by CPR. We just talked about that guy at Huntington Beach. You can also have a hypoxic stroke, which is from brain anoxia. Any questions? That really doesn't factor in because it's not a stroke caused by a condition. Well, it is stroke caused by a condition, but from different than what we're talking about here. So the third one they have listed there, a transient ischemic attack. That is not a stroke because the brain tissue does not die. A transient ischemic attack is like angina for strokes. You have all the signs and symptoms of a stroke, but the tissue doesn't die. And with rest and oxygen, it resolves. So it's not really a stroke, it's a stroke mimic.
And it still cause like,
Oh yeah, it looks exactly like a stroke. You have all the signs and symptoms. Well, rest and oxygen, it goes away.
oh, that's what we can do.
Well, they're common. And they're abbreviated TIAs. Well, people won't call them transischemic attacks, they'll call them TIAs. It's like an AMI. Abbreviation. All right. Ischemic strokes. 4 out of 5 strokes are ischemic strokes. If untreated, these are horrific, debilitating strokes. They'll leave you in a nursing home for the rest of the patient's life if they even survive it. Good news is, over the last 15 years, medication's been approved that you as EMTs, if you identify it and get a timeline, and are able to get them to a hospital and get the medication on board, you can 100% reverse it and stop it from happening. order to teach you how to do that today. So what causes ischemic strokes? And then what causes heart attacks? Atherosclerosis. Plaque forms, plaque breaks off, blocks the artery, everything distal to that blockage dies. It doesn't get refused. Any questions?
What's the timeline on this, like a heart attack? Is it
3 hours.
3 hours? Okay.
Actually, it's 90 minutes,
90
but
minutes.
up to 3 hours.
Okay.
The best results are 90 minutes.
Gotcha.
You have up to 3 hours, but generally there's some deficits between 90 minutes, 3 hours, but not as many deficits as if over 3 hours.
Gotcha.
So you can also tell which side of the brain is being affected sometimes by the signs and symptoms. Aphasia is a vocabulary word you have to know. Aphasia is the inability to speak or inability to understand speech. So receptive aphasia means you can talk, but you have no idea what anyone's saying to you. So people will say something to you, and then you'll say something completely different, which is what we call inappropriate over the last year, right? Say, can you tell me what day it is? It's like, the cat is orange. Like, today is what day? The cat's orange today. They can't understand what you're saying. And then expressive aphasia is they can hear you, but they can't speak. That's typically an infarct to the left side of the brain.
Can they write out a response?
Huh?
Can they write out a response, or is
They're
it?
not right-handed,
Okay.
because
can they
usually the
left
right
out
side of
a
the body also goes plonk.
Gotcha. But they can interpret and like respond theoretically.
Shake their head, they can answer questions by shaking their head. Then the right hemisphere, you get dysarthria, which is they can understand you, but when they talk, they go. And they generally don't know that they're saying. They're saying, "Help me! I think something's wrong." Is what they're hearing. That's not what's actually happening. Pretty weird stuff. It is terrifying. Strokes are some of the most terrifying things you will face in EMS. That and an unexpected seizure, especially a hemorrhagic stroke seizure. I've seen EMTs fly 6 inches to 18 inches off the bench, and someone goes into a seizure they weren't expecting from hemorrhagic stroke. So usually do a cat cry, just a scream, and then they start violently shaking. It's like.
I witnessed my grandpa have a stroke, and he was getting like angry. He was like,
yeah, your personality changes.
Yeah, you were asking like, "What's your name?" I don't know. I don't give a shit what my name is.
Is it hemorrhagic stroke?
I'm pretty sure.
Pretty sure hemorrhagic will do that.
Yeah, he was just getting mad that he couldn't remember it.
And then he quickly deteriorated.
Yeah.
Yep. We're gonna go over that in just a sec. Yeah, that's the signs of a classic hemorrhagic stroke. You ruptured an artery and sent it right properly.
Okay.
So, ischemic stroke, you know, signs and symptoms. They get paralysis on one side of the body. They lose motor function. They get facial droopness, ataxia. A lot of times aphasia, they can't speak, and an altered level of consciousness. So, for the time, a timeline is incredibly important. First thing you want to know is, if at all possible, find out when the signs and symptoms started. If they woke up with it, that's tragic. But if they were eating dinner and talking, and then suddenly dropped the fork, couldn't talk, and started drooling with their face drooped, if you can get that exact time, it's critically important. Because again, the drug that can reverse that is one of the most dangerous drugs on the planet. It can be fatal if given wrong or incorrectly, or no benefit. So I'm going to teach you guys right now how to deal with this. So we're going to do a test called the Cincinnati Pre-Hospital Stroke Screen. It was developed in this place in the United States called Cincinnati. But you'd never guess that if I hadn't told you. So it's a 3-step test. All right. First thing you do is have them hold their arms straight out in front of their body. And then preferably if they can, close their eyes and turn their palms up. That gives you good motor function. If they can't do that, it's a positive sign. So they go, okay, that's a positive sign. If they can do that, then that's a negative sign. Next thing you do is have them grimace, show me your teeth. Like this, you can do it right out. Then what you look for is facial droop. I don't have any facial droop, that's good, that's negative. If there's a straight slight facial droop or a big facial droop, that's a positive sign. Then the next thing you're asked to do is say the sky is always blue in Cincinnati, or something that uses a lot of vowels and consonants. If they can speak it clearly, that's negative. If they slur any of it, that's positive. If they are positive on all three of those tests for the Cincinnati Breast Stroke Screen, they have a 90% chance of an ischemic stroke. And if you have a timeline, if you can get them in and get a clot busting drug within 90 minutes, they can have 100% reversal of it and actually save them from spending the rest of their life in a nursing home or death. Any questions?
Does that test work? Stroke?
No, only ischemic. Only ischemic strokes. But that's 80% of the strokes, so. Any questions? You can get them in 90 minutes of onset. You have an excellent chance of reversing it. But you've got to get them into a stroke center in 90 minutes.
Everyone in Fairchild?
Both hospitals in Mount Shasta are stroke centers, or in Siskiyou are stroke centers. Fairchild and Mount Shasta are both. Any questions? Timeline's not as easy as it sounds, so you gotta identify it. Someone's gotta call 911 or get them to a hospital. They have to get to the hospital. They have to do a CT scan before they give the medication. They have to make sure it's not a hemorrhagic stroke. You give a clot busting drug to someone that's already bleeding in their brain, you have 100% killed it. So you have to do a CAT scan first. The hospital has to do a 2-page list of rule outs before they can give that drug. So your timeline is narrow. What's that? TPA or TNK. TNK is what most reads like now. It works actually faster than TPA. It doesn't work faster, but it gets put together faster. It's already ready to go, and you just push it. Whereas a TPA, you got to mix it, drip it. Any questions on the Cincinnati pre-hospital stroke screen? Accurate timeline is essential. Don't make it up. You have to be sure of the timeline. Unfortunately, most people do not call 911 for signs, symptoms, of stroke. They call Uncle Charlie, who then calls Aunt Bessie, who then calls Cousin David, who used to be married to someone who used to know a doctor. Then finally, somebody about 20 minutes later calls 911. Then it takes about 5 to 7 minutes to get the dispatch out. Now we're at 30 minutes. Another 10 minutes to get on scene. Now we're at 40 minutes. Another 10 minutes back. Now we're at 50 minutes. See what I'm saying? You gotta get to the hospital 10 minutes. Now we're at an hour. Then you gotta get them in, get the drugs made, get the CAT scan done, get the 2-page rule out chart done. It's very, very difficult. It's a very narrow window. But here, this is someone that knows more than me. This is gonna be one of the silent videos. This is blood moving through an artery. As you can see, plaque is building up and clots are building. This is causing decreased blood flow to the brain. Then a clot breaks off, blocks the arteries, everything. This is that infarcts. This is an ischemic stroke. Every time you listen to new voiceovers, what's that? Thank you.
Yeah.
I got a future of voiceovers every time when they fire me from here.
It's one joke away.
Yep. One joke. Well, yeah, one wrong joke away.
This is how AG1 works to upgrade your health routine. By combining
A stroke occurs when the blood flow in part of your brain is blocked. After just a few minutes, the starved brain cells begin to die. Normally, the brain receives blood via two major pairs of arteries, which branch throughout brain tissue and supply your brain cells with a constant flow of oxygen, glucose, and nutrients necessary for their functions. In one type of stroke, ischemic stroke, an artery in your brain narrows or becomes completely blocked, preventing normal blood flow. The blockage may be caused by a blood clot, also called a thrombus, which forms in an unhealthy artery of the brain. The lack of blood flow causes the tissue the artery supplies to become starved or ischemic. Similarly, the blockage may be due to an embolus, a blood clot that forms elsewhere in the body and travels to the brain. The embolus lodges in a narrowed artery and obstructs blood flow. Immediate treatment for your stroke may help to minimize brain cell injury and death. If you have an ischemic stroke, you may be given medication to break up the clot causing your stroke. Later, your doctor may recommend surgery, such as carotid endarterectomy, to reduce your risk of having another ischemic stroke.
Questions?
Was that them taking out the,
What's that?
the surgery that they were just talking about?
So yeah, what they can do is under interventional radiology, they can do what's called a thrombectomy. Where they go in through the femoral artery, just like going for the stent for the heart, where they go through the carotid and they go to the brain and they have a suction, and they suck it out. Or they'll go in and poke a wire into it, and then they'll grab it and they'll try to pull it out that way. Same thing while they're watching it on the television screen. Not really yet. Coronary, the cerebral arteries are a lot different than coronary arteries, are a lot smaller. What do we do? Watch their airway, make sure they're breathing adequately, give them oxygen 2 liters per minute, titrate to 94%, keep their head elevated 30 degrees if possible. Get them to the closest stroke center with a stroke alert called as soon as possible, so they got the CT scan ready, and the drugs ready. The earlier they know, the faster they can treat. The earlier the notification comes from EMS, the better the chances.
Activase, also known as recombinant tissue plasminogen activator, or TPA, is the only drug approved by the FDA for treatment of stroke. Growing plaque can rupture, promoting thrombus formation by activating the coagulation cascade. Platelets and red blood cells aggregate at the site of injury, causing further narrowing of the artery. This impedes blood flow even more and causes turbulence in the artery. It also increases the likelihood of thrombus formation. As the thrombus grows, it causes increased vessel narrowing, leading to partial or even complete occlusion. The occluded artery leads to ischemia and tissue necrosis. When a piece of thrombus breaks off, it's called an embolus as it travels up the artery. During a stroke, ischemia can progress to infarction. Beyond the infarction lies still viable tissue called the penumbra. Cells within the penumbra are potentially salvageable if blood flow and vital oxygen are restored promptly. The penumbra is the focus of fibrinolytic treatment. Now let's look at the thrombus itself. Inside the thrombus are strands of fibrin. the protein that forms a clot. Enmeshed within the fibrin is plasminogen, the inactive precursor of plasma. Activase is administered by IV infusion within 3 hours of acute ischemic stroke symptom onset. Activase binds to the fibrin in a thrombus and converts plasminogen to plasmin. Plasmin then breaks the strands of fibrin and dissolves the clot. As the clot dissolves, blood flow is restored, and viable tissue may be reperfused. Although the original infarction remains, when surrounding cells in the penumbra are saved or reperfused, function may be restored. Activase, the one TPA for stroke, is the only drug approved by the FDA for this indication. Activase is indicated for the management of acute ischemic stroke in adults for improving neurological recovery.
All right, here's the other way they can take it out, since you asked.
Treatment of acute ischemic stroke with clot retrieval device. Ischemic stroke is a condition in which normal blood flow to the brain becomes interrupted. When a clot becomes lodged in one of the arteries that supplies blood to part of the brain, the tissue is deprived of oxygen. Clot removal devices are designed to treat ischemic stroke by removing the blood clot from the artery. The clot removal procedure begins by advancing a guide wire through the blood clot within the artery. A microcatheter is advanced along the guide wire until it is beyond the clot. The guide wire is retracted and the clot retrieval device is advanced through the microcatheter and deployed as the microcatheter is retracted. Once unsheathed, the device expands, pushing the clot to the walls of the artery and immediately restoring partial blood flow. Over the next 2 to 5 minutes, the device becomes embedded in the clot. The clot retrieval device, along with the blood clot and microcatheter, are removed from the body. Blood flow is restored and verified with imaging. The entire procedure typically takes less than an hour.
It's basically a stent.
When it grabs the clot, pulls it out instead of staying in. Sending, you gotta be in the interventional radiology, it's hard to get in there in time, get that done. It's gotta be fast, real fast. All right, so that brings us to hemorrhagic strokes. This is when a vessel ruptures the circle of Willis.
Bruce?
No. Arnold. Probably most of you don't know who Arnold and Willis are. Sure, what you talk about, Willis?
Oh, yeah.
The show called Different Strokes. Huh? Yes, they are. They don't even know about it.
Your heart pumps blood to your brain through blood vessels in your neck. These blood vessels, called arteries, branch into even smaller arteries that bring blood to your brain cells. Some of these small arteries join each other to form a loop known as the Circle of Willis. The walls of the arteries contain special muscle and elastic layers that help them adapt to the blood pulsing through them. Sometimes diseases, injuries, or birth defects can cause a weak spot in the wall of the arteries in the Circle of Willis. These weak spots usually form where arteries branch. Over time, the pressure of blood flowing through the artery stresses the weak spot further. The constant blood pressure can cause the weak spot to balloon out and form a bulge called a cerebral aneurysm. This cerebral aneurysm is the most common type, called a saccular or Barry aneurysm. Over time, the aneurysm may grow and push on nearby brain tissue or nerves. Blood may also leak from the aneurysm. If its wall gets too thin, the aneurysm can burst or rupture and spill high-pressure blood into the space around your brain. The blood presses on your brain tissue and can cause injury to your brain cells. Chemicals in the escaped blood can irritate other brain arteries and cause them to narrow. As a result, your brain can swell, leading to serious brain injury. Common symptoms of a ruptured cerebral aneurysm include sudden severe headache, sometimes called a thunderclap headache, problems with your vision, such as blurred or double vision, nausea and vomiting, a stiff or painful neck, or confusion. An unruptured cerebral aneurysm may not cause symptoms, but large unruptured aneurysms may cause headache and pain near or behind one eye, double or blurred vision, a drooping eyelid, and numbness or weakness on one side of your face. A ruptured cerebral aneurysm is a medical emergency. If you are having symptoms, seek immediate medical attention. If you have a ruptured cerebral aneurysm, your doctor may recommend surgical clipping or endovascular coiling. In surgical clipping, your surgeon will make an opening in your skull near your aneurysm and place a small metal clip onto the stem that connects the aneurysm to your artery. The clip blocks blood flow into your aneurysm. In endovascular coiling, your doctor will put a plastic tube called a catheter into a large artery in your groin. Using a live X-ray view, your doctor will advance the catheter through your arteries until it reaches the aneurysm. Through the catheter, your doctor will insert one or more flexible wires into your aneurysm. The wires will coil up and cause a blood clot to form inside your aneurysm, which will block off the aneurysm from the rest of your artery. In a similar manner, if you have an unruptured cerebral aneurysm, your doctor may recommend surgical clipping or endovascular coiling. In addition, if your aneurysm is small and not causing pain or other symptoms, your doctor may observe your aneurysm for a period of time before performing either of these procedures.
Any questions?
Often would they use, I believe it's iodine that they would put into the veins in order for it to show up on imaging. How often do they use that for this, or is that even?
Contrast CT?
Yeah.
I'm not sure. Because I can never remember if it's non-contrast or contrast CTs, they look for hemorrhagic strokes. I guess non-contrast. But I'm not positive. So hemorrhagic strokes have much different signs and symptoms than ischemic strokes. They get a sudden severe thunderclap headache. Personality changes, they lose consciousness rapidly. They often have projectile vomiting. They will vomit so forcefully it'll actually vomit right into the wall. Have signs of Cushing's triad, intracranial pressure, below pupil, high blood pressure, bradycardia, irregular respirations, and often a sudden seizure. Those are the classic telltale signs of a hemorrhagic stroke. Very different from an ischemic stroke. These, unfortunately, cannot reverse. These generally have very poor outcomes.
My grandpa had his getting checked into the ER while he was having like a breathing problem with the COPD, and he lived. I don't know if it was one of those. He's still alive.
I mean, I've been there. Was he at a stroke center?
He was just at the Mount Shasta Hospital because he has.
They can't do a hemorrhagic there, they can only do ischemic. If it might have been ischemic, they may have given him the drug and reversed it.
Okay. Because, yeah, he lived.
So very possible, or it's just a small bleed.
Yeah.
They're able to stop it. The same thing too, so there's also, sometimes this could be caused by some of the newer, anti-clotting drugs. And there's medications that can reverse the anti-clotting drugs and stop the hemorrhagic strokes in the tracks too. So,
okay.
So it could have also been that. Yes.
So when you're talking about like mood changes of somebody experiencing a stroke, like does it matter, or I mean, would the mood change depending on like, or whatever they're doing on where it is in the brain? So like getting angry during a stroke would only really indicate like where.
Good.
Or it could indicate where it is.
Like frontal lobe, but I don't
Yeah.
really, you'd have to ask your neurologist to get specifics on that.
Okay.
But yes, that's what causes mood changes, the infarctions of the brain in those areas.
Yes. HTN.
The what?
Hypertension.
HTN, yes, hypertension, high blood pressure. Questions? These people, you gotta get them to neurosurgeon. They need neurosurgery. That's the only thing I was gonna say. Any questions? That brings us to stroke mimics. There's 3 stroke mimics. There will be test questions on those. First one is a transient ischemic attack, also as a TIA. It has all the same signs and symptoms of an ischemic stroke, but it goes away with rest and oxygen. It's basically angina to brain cells, just like a stroke is a heart attack to the brain. Sometimes people call it a brain attack. It's the exact same thing, just a different part of the body. Any questions? So hypoxic strokes, we talked about a little bit, those are different than ischemic or hemorrhagic. This is when you haven't been breathing or you've had an obstructed airway or not been breathing adequately for a period of time and the brain dies.
What's that period of time?
Everybody's different. Generally 10 minutes. I can tell you for fact though, there are miracles that we don't understand sometimes. For instance, I had a guy, they were building an international scout from scratch. They found a frame in a junkyard. They're all Cal Poly engineering students. And they had literally built this thing as an ultimate off-roading vehicle from scratch. Well, it wasn't street legal, so they were driving it on a back road, Black Butte Lookout Road, by Spring Hill Road. Actually, it's called Powderhouse Road. And another car was coming, so they tried to four-wheel it up, but it was off balance, and it rolled, and it ejected one when he landed prone on the ground on the dirt road, and then the Scout landed on top, which is like a Bronco, basically. And it completely crushed him into the ground, and he was under there for 28 minutes.
Oh my God.
He was dead. And this was on a summer afternoon, it wasn't cold or like hypothermia sort of cells. It was a hot summer afternoon. And we got him out there, his entire airway was completely clogged with dirt. And so I just kept suctioning it, trying to pull dirt out of his airway. And we were doing CPR on him, and he was dead for over 30 minutes, which there should be no possible way of surviving. And all of a sudden, once I got him intubated, got an airway back, and pulse came back, and we basically figured he was going to be from a massive hypoxic stroke. So 4 days before that, I'd also had a girl, they crashed into a tree, and she was crushed between the seat and the dashboard. And she didn't go into cardiac arrest, but she'd only been breathing at 4 breaths a minute for God knows how long. It was down at Castella, so the time we got down there, it was like almost 25 minutes. And when we started ventilating her, same thing, she went into immediate decorticate posturing seizures. And that was in 2002. She's still in a vegetative state 22 years later. Massive, massive hypoxic stroke. The guy 4 days later,
that was actually dead for half an hour. 4 days later was doing calculus programs while still on a ventilator with the neurosurgeon. And they extubated him, then he finished as a Caltrans engineer right now. He's got 3 kids.
Wow.
No deficits. Sometimes it's just, we don't know. We just don't know enough about it. And they were the same age. They were the exact same, they were the same freaking class.
Oh, man.
Yeah. And had 2 completely different outcomes in the same week. Yeah, so hard to say. So TIA is the first stroke mimic. Second one is hypoglycemia, which is low blood sugar. There's not enough glucose in the brain, it will act just like a stroke. Until it gets sugar. And the third one, which would be the most common stroke mimic you'll see, is a post-ictal state. So a post-ictal state is the state of your brain rebooting after a seizure. So a seizure is basically ventricular fibrillation of the brain. The organized neurons in your brain electrical pathways go crazy. And it causes just complete electrical chaos, and your body goes into a full-blown seizure. And then it has to reboot. But your brain doesn't reboot with the heart, the SA node just takes over and starts beating again. The brain is like more like a computer or a cell phone, and it's got to go through a complete reboot process. And it can take anywhere from 10 minutes to 40 minutes. And while it's in that reboot process, if half the body comes online first, it mimics exactly like a stroke. Those are your 3 stroke mimics. I promise you, there will be test questions. And scenario-based critical thinking test questions. Any questions about stroke mimics? All right, so what causes seizures?
Es in sich, oder besser unter sich. Also, das Bett ist gemacht. Jetzt mal sehen, wer sich hier mit Schwung in die Falle haut. Da kommen sie schon, die ersten Matratzentester.
Ja.
Hallo. Schnell geht's doch gar nicht.
I was taking a bath on about a Saturday night. Sorry.
It's not really how you got seizures. Good comic relief. So seizure is when your brain goes completely haywire electrical, still poorly understood. As a matter of fact, epilepsy is a blanket term for a seizure disorder that we have no idea what's causing. So what happens is all the muscles in your bodies contract violently, and you lose control of all bodily functions, including urine and stool. That's for grand mal seizures, also known as tonic wine. You can also have what's called a petit wall or an absent seizure, whereas then the brain just completely checks out. Causes no motor dysfunction, but basically it's like turning the television off, it's just big, it's gone. Then it slowly reboots. Real bad when you're driving a car. Yes.
I have a question. The
Yeah.
guy who was in Huntington Beach, it looked like he evacuated his bowels.
Oh, yeah.
So
When you
that,
die, that happens too. Everything
okay,
relaxes.
so just like the pulseless apneic patient.
Pulse
Likely gonna
patients
just
will
ignore it.
always let go of all their bodily functions.
Mhm.
That's what I know too. If someone tells you when they're doing CPR, the jaw can go, let's do an airway, they go, the jaw's seized shut. You cannot have anything seized shut when they're pulseless and apneic. If their jaw is seized shut, that's called rigor mortis.
Right.
It's time to stop CPR.
My sister, for like most important finals, she had a seizure in the middle of it and she just got passed, so that happens to me.
That won't happen in this class. I can guarantee it.
If I start seizing, you're not gonna give me an A?
Nope.
Oh, Lord.
This is about saving lives. You have to be able to pass the curriculum.
It's really counting.
Well, unfortunately, it chose my class.
Normal brain activity shows neurons firing as different regions of the brain become activated. Notice how the different neurons alternate their firing patterns as they communicate their messages throughout the brain. During a seizure, large groups of neurons fire simultaneously, demonstrating hyperexcitability. This activity can be likened to an electrical storm.
This was much better, so the same background music.
Simple partial seizures. Person remains aware, cannot completely control function or behavior, commonly referred to as auras. These seizures or auras are characterized by strange or unusual sensations, a whirling or tenderness in the stomach area, odors, or visual abnormalities. Other characteristics of SPS include sudden or restless movement, hearing distortion, and a sudden sense of fear. Alteration of consciousness or memory is generally not associated with simple partial seizures. Complex partial seizures. Person experiences impaired consciousness, cannot completely control function or behavior. Complex partial seizures are often preceded by an aura. Auras are not unconscious acts. They are the funny smells, tastes, déjà vu, fear, and many other conscious warnings patients may experience. They are often identified by the manifestation of complicated motor and sensory action. There may be some change in consciousness or memory. A partial seizure seen here in the temporal lobe may spread, becoming a generalized seizure. A generalized seizure affects the neurons of the entire brain. A generalized convulsion occurring in two phases. Tonic phase, stiffening of the muscles, the person loses consciousness and falls as the body grows rigid. Clonic phase, body extremities jerk and twitch. After the seizure, consciousness returns slowly. When the person wakes up, they are often confused or disoriented. Characterized by a complete loss of awareness. The person may stare into space and appear to be daydreaming or in a daze. Absence seizures are not preceded by a warning, aura, and are followed by normal activity by the individual. There is very minimal movement during the actual seizure, so many times it may go unnoticed by others. Some types of seizures, especially if prolonged or repeated frequently, can damage the brain.
Any questions? So things that cause seizures, well, epilepsy is just a general umbrella term for we have no idea what's causing it. High fevers in children can cause seizures. Those are called febrile seizures. They have nothing to do with epilepsy or even indication that they'll have seizures down the road. It's strictly from the, it's to break the fever. Metabolic disorders such as hypoglycemia and brain tumors can cause, actually, brain tumors are structural, not a metabolic disorder. But metabolic disorders such as hypoglycemia can cause it. Poison and drugs can cause it. And of course, structural changes such as brain tumor. Any questions? What does a seizure look like? You're gonna see about 5 fake seizures for every real seizure that you see. Because people fake seizures to get in the ERs, try to get food and stuff. It's pretty sad. State of people that are extremely hungry and cold and wet, it's a good way to get out of the environment. But in real seizures, they have full tonic clonic. Once you've seen it, you'll know it. They almost always bite their tongue or bite their cheek. They have no control over it, and they lose control of their bladder and often stool. The last 3 to 5 minutes, and it's terrifying to see. When people go like this, they're not really seizing. If they have no oral trauma, they didn't wet their pants, they probably didn't actually seize. Unless it was a withdrawal seizure, which is something completely different. Then they'll also have a post-ictal state lasting 5 to 20 minutes longer. Sometimes up to an hour. The brain reboots. Any questions? And usually that post-ictal state, they're not able to talk for about 20 minutes before the speech is able to reboot. Any questions? Yeah.
So what's the other one other than the grand mal?
Petite mal or absence.
You can have either of those on any of the different types of seizures. So if you have it from a fever, you could have a grand mal or a petite mal.
I've never heard of petite mal seizure.
What?
I've never heard of petite mal seizure.
So
Possible, I guess, but I've never heard of that.
what about the other ones?
Generally, it's grand mal seizures that they have on fever. And it's hard to tell too, because they generally don't get the oral trauma, but generally they're in diapers, so you don't know if they've lost control of the bladder or not.
So like for a metabolic or a structural, those are usually grand mal as well.
Yeah. Those are very bad. Yes.
Naloxone, they're saying that, to possibly expect a seizure from administering that.
Rarely, yes, it is a
But rarely,
side
so is
effect.
that a withdrawal seizure then, and not a?
I don't know the etiology behind why people, I've only seen it once from giving Narcan where someone sees.
Okay, so it's not like a
It's
routine.
pretty rare.
Okay. Okay,
But yes, it is a potential thing that can happen.
gotcha.
Yeah, the only time it's not happened, I gave 3 different doses of Narcan to a guy that wasn't breathing, he seized each 3 times. So I called base hospital, this officer says, well, stop doing it. You just bag him. It's like, oh yeah, I guess I could just bag him up.
Yeah. And is the bite block thing something that's like
Not anymore, don't use-
antiquated or? It didn't
Bite
seem
blocks
like-
are no longer
That's
a
what I
thing, they
thought.
break teeth and obstruct airways.
Okay. So
My original EMT kit had a bite block that was a corkscrew. That you could put in their teeth that are seized, you could corkscrew the mouth open to get an airway.
Oh, wow.
Horrible idea.
That's terrifying.
Yeah, we don't do that anymore.
Gotcha.
So what do we do procedures? Clear everything out of the way and let them seize. Stop there and do whatever you could possibly do to prevent them hurting themselves. And let the seizure ride it out, and then immediately open their airway when they're done seizing, because most of the time, they cannot protect or open their own airway in the post-ictal state. That's the #1 thing that kills epileptics, is when they stop seizing, they end up with their airway closed in a post-ictal state, especially children. They got a big bobble head, soft little anterior airways, and if they stop seizing with their head forward, they're dead. When I was a kid, they used to say, oh, little Joey swallowed his tongue, it was so sad. They didn't really swallow their tongue, they landed with their airway obstructed by their tongue. And when you're post-ictal, you have the ability to move your head to open your airway. So very important to let them finish seizing, clear everything out of their way. As soon as they're done seizing, open their airway, be prepared to ventilate. Any questions? Yes.
Should we secure the airway with adjuncts?
No, because once they come out of post-ictal state, they're gonna wake up and have a gag reflex. That's gonna be it. Any questions? Good questions. All right, now for the most common 911 medical call, altered mental status, because it's a huge catch-all. AEIOU, yes. Maybe we'll force your hands up there. Think of all your vowels. Yeah. Think of Anna. AEIOU tips. So if someone's altered, it's gonna be one of those things. AEIOU tips. Alcohol, epilepsy, affection, opiates or overdose, uremia, trauma, insulin, poisoning or psychosis or stroke seizures. That covers all of your altered mental status conditions. It'll be one of those things. You got 9 things to do. Just think, AEIOU tips. Vanna, have any tips for you? Any questions? Hypoglycemia is one of the most common. Diabetics take too much insulin. Don't eat enough, don't get enough sugar in. All the insulin takes all the sugar out of the blood to the cells and there's no sugar to replace it. So they get an altered mental status pretty quickly. Any questions? The late stages of hypoglycemia can cause CJETs. Any questions? Also, hypoglycemia can have people act like they're drunk. The other opposite end of hypoglycemia, hyperglycemia can do the same thing. And hyperglycemia, if they're in diabetic ketoacidosis, they'll also have a fruity smell in their breath similar to alcohol. So a lot of people in diabetic ketoacidosis get mistaken for getting intoxicated when they're not.
Fruity smell?
Huh?
The fruity smell?
Yeah, fruity. The acetone has got like a, smells like nail polish.
It's not bad. That's not.
It's kind of like acetone, like nail polish remover. It reminds me of. That's what it reminds me of. Sure, that's not just their breath. So what do we do if we do a low preventable status? We make sure they got an airway, we give them high flow too. If they're unresponsive, we don't know how or why they got there, no one witnessed it, we put them in full spinal precautions, because for all we know, Bigfoot ran out of the woods, hit him in the hip with a bat, and then ran back into the woods. Questions?
You commonly find Bigfoot related injuries.
No, but I do know for a fact, Bigfoot is the #1 annual championship of hide and go seek every single year. Always wins. The goat. Any questions? Yeah.
Oh, where do we find these,
Bigfoots in Humboldt.
sorry, the slideshows?
COS EMT. Actually, so you got a couple spots. So if you go to YouTube, every one of these presentations is on YouTube under COS EMT, all caps. COS space EMT. Then there's also a website that there's a link to on the first day handout that I emailed you. To a website that's not really well updated, but it's updated well enough that you can get these slideshows. Any questions? All right, let's see what you guys learned. Got a couple of case histories here. You're dispatched to a single family home for a man with altered level of consciousness. What do we do first? Suicide on the patient's grandson meets you at the door. Nature of illness, abbreviated NOI. Grandson says patient complained of severe headache and then vomited. Got one patient and 3 or 4 bills. You're pretty well set. What's next? Primary assessment. General impression is an early 60s male sitting in a bathtub covered in vomit, appears to be very ill. His eyes open to pain. He's got vomit on his lips, but his airway is clear. He's breathing adequately at a rate of 28 breaths a minute and deep. He's got a bounding radial pulse. What's next? Got the history. Onset 15 minutes ago. Provoked while he was looking for his car keys, taking his grandson home. Quality and radiation did not apply. Severity, patient complained of a severe headache prior to a decreasing level of consciousness. And he hasn't been speaking since about 3 minutes before you arrived. Allergies, grandson says he's allergic to penicillin. Medications, grandson brings you a tray. It has Inderal, which is for blood pressure. Hydrochlorothiazide, which is for blood pressure. And KCL, which is potassium, also for blood pressure. Grandson says he thinks his grandpa's got high blood pressure. Those medications, I can guarantee it. And then when we got to a patient grandson, we're going to go back to grandson's house and wait for his parents. When grandpa suddenly had a severe headache, vomited straight into the wall, then crawled to the bathtub, began mumbling, unable to understand what he's saying. What's next?
Secondary assessment.
Secondary. His blood pressure is 240 over 130. His pulse rate 60. Rest rate is 28. His eyes open to pain. He's incomprehensible and he withdraws from pain. What's his GCS?
Is it 7?
No. You said 8. How'd you get 8?
Well, the eyes open, which would be verbal, which would be confidence, which would be.
Yes. 4. 8. So 2 plus 2 plus 4 is 8. Good job. Strong work. All right. His right pupil's blown. He's incontinent of urine and stool.
And second set of vital signs, is blood pressure is increasing, his heart rate is decreasing. What's wrong with this? So based on the positive findings of your assessment, what's wrong with this patient? It's a classic hemorrhagic stroke. What is that? High blood pressure, low pulse, irregular respirations. What is that? Very good. Guys, you're getting ready, man. Making me feel good about the midterm. This dude needs decent. All right, I got another one. You're dispatched to the local city park for a man down. What do you do first?
Inside.
Inside's up. Everybody's wearing their BSI. Nature of illness. Patient was found confused by police in the park. Number of patients, 1. You and your crew have an engine company on scene. It's confused with unknown etiology, so you guys take spinal precautions. What's next?
Primary assessment.
Primary. Your impression is he's a hygiene challenged male in his mid-30s. Eyes are open, but he's not speaking. You turn, he's got ultra conscious, airways clear, he's breathing adequately, he's got a weak rapid pulse. What's next? Nobody knows him, he's not talking. What's next? All right. Blood pressure 120/70, pulse rate's 124, rest rate's 20. His eyes are open, he's not speaking, and he doesn't follow commands, but he moves his arms purposely. What is his Glasgow Coma scale? No.
Oh, eyes are open, comma, verbal patient is not speaking. So,
Eyes are open. How many points is that? 4. He's got no verbal. How many points is that? 1. 4 plus 1 is what?
5.
What is purposeful movement?
5.
5. 5 plus 5 is
10.
10.
I thought 5 was movement in reaction to pain, not
That's 4.
relaxation of pain, but.
No, purposeful movement, but not following commands. They're moving, localizing pain.
Yeah.
But,
Okay.
or any purposeful movement without following
Okay.
commands.
Purposeful movement also follows. Okay.
He's bleeding from a wound on his tongue, otherwise his head's negative. Everything else is negative until you get to his pelvis, he's incontinent in urine. Second set of vital signs are about the same, except his Glasgow's eyes are open. He's verbal now, but confused. He's now obeying commands. What's his Glasgow now?
14.
14, correct. Loses 1 point for confused. Based off the positive findings of your assessment, what's wrong with this patient? Post-ictal state from a seizure. Wow, you guys are good. This job is so hard. You come, you do an assessment, you look at the positive findings, you form a primary impression. It's so hard. Look how good you guys are. All right. All righty, let's do this. Let's go to lunch. Come back at 12:15. Take our midterm. We're halfway through, folks. You can see light at the end of the tunnel. It's right there. See light at the end of the tunnel?